carbon dioxide, oxygen, nitrogen, and hydrogen, and calcium, and some other minor minerals are there, potassium, sulfur, sodium, chloride, and all that, So we are all made of this. We are made of protons, neutrons, electrons. So what are these proton, neutrons, electrons are made of? They're made of different combinations of, different atoms moving around it. The hydrogen atoms, carbon dioxide, oxygen atoms, nitrogen atoms, and all those things. This thing. So this is what our body. But what this body, this is a nitrogen ion, this is carbon dioxide, oxygen, and hydrogen. Okay. So our body is made of these four basic elements, CONH. Okay. So different combination of CONH give rise to different tissues, but these combinations gives one basic property to the body. I will come to that later. Other thing we need to understand this is the morning I spoke about magnetic pole. Earth itself acts like a magnet, huge magnet. We have a north pole and south pole, isn't it? So the presence of hydrogen ions within the body, these hydrogen ions, they also act like a mini uh, magnets. Okay, these hydrogen ions, and they're free floating. They are not oriented in any one direction. They are free floating small mini magnets. They are always rotating in different directions, and the billions of such hydrogen ions within our body. Okay, so what happens is when these hydrogen ions are subjected to a powerful magnet, okay, then they get aligned to one particular direction, depending on the polarity of the magnet. As they say, the opposite poles they attract. Like that, these hydrogen ions, they get this thing, they get aligned to one this thing. So then what they do is in MRI, they subject the patients to a strong magnet. Okay, strong magnet. So these magnets, so these hydrogen ions get aligned. Then what they do, they subject the patients to radio frequency waves. When the radio frequency waves are applied, again these hydrogen ions start deflecting and coming back. Okay, these movements, these hydrogen polarity, that will be documented and converted into image pixels. Okay, and these image pixels is what give rise to an MRI picture. Okay, this is a great, wonderful. Whoever thought about this concept is a wonderful idea. Okay, basically what is required is to get this hydrogen and aligned and non-aligned is, that is a strong magnetic power, and second thing is a radio frequency field, and the third thing is to take this a computer algorithm which studies these alignments and gives us a picture. Okay, beautiful picture. Okay, so based on that we make an assessment of MRI. So what are goals of imaging? In any image, what we get done is, one is identify the lesion, and second is site of the origin, where exactly origin, and what is the anatomical relationship, where it is originated, where it is going, and what critical structure is close by. That is, next is differentiate the pathology. Okay, next is differentiate pathology and recognize if any infiltration is there, bone erosion is there, we have to recognize that. Okay, and also we need to assess the vascularity and distinguish the tumor from other lesions. And imaging also is used to plan the surgical approach. These are the fundamental principles of imaging, why we use it, and that is efficient. Okay, so when do we do MRI in the nose and paranasal sinus? The specific yeah, this thing reasons. The one is whenever there is a complicated sinonasal disease, we do an MRI. Okay, we do an MRI, and also to discern secretions and mucosa from masses. Okay, so what happens? CT cannot differentiate between a plain CT scan, non-enhancing CT scan cannot differentiate between secretions and any masses or anything. Again, you will have to give a contrast enhancing agent to differentiate that. Okay, whereas MRI can differentiate between secretions and masses, and also invasion of the skull bases. Okay, that MRI, that CT scan may not be able to detect unless obvious bone erosion is there, whereas MRI is very, very sensitive and specific to the invasion of the skull base, anti-skull base mainly. Now that more and more surgeons are taking up anti-skull base surgeries. Okay, and also foraminal extensions. See, some of the lesions are known to extend along the foramina. During that COVID time, we had lot of black fungus or mucormycosis cases, and these mucormycosis along the nerves. There was neural spread or perineural spread along the nerves to various foramina. Right, intracranial spread was there. Some of the tumors also have foraminal extension. So that is when we need that MRI. Okay, and also to assess the intracranial extension and involvement of the dura and involvement of the brain matter, and the MRI becomes very handy. So these are some situations when we have to get an MRI. And MRI, what are the common MRI we do it? That is MRI, this thing we use. Depending on the signals, these MRIs are classified into T1 weighted and T2 weighted images. So what's the difference between, how do we recognize this T1, T2 is? So T1 is, it's known as anatomical. Okay, the anatomical images. T1 weighted images, they depict the normal anatomy of the body. But the only thing is, it cannot show the bone. Okay, MRI cannot show the bone, whether T1 or T2 weighted images. Okay, that is the T1 this thing. Whereas T2, it is almost similar to this thing T1, but it enhances or it brightens all the fluid content in the body. As you can see here in the picture, this is anatomical picture. Here all the CSF and any fluid is there, non-flowing fluid. Okay, the static fluid like edematous fluid or anything, it is brightens up. Okay, for us head and neck surgeons, how do we identify T1, T2 weighted images? Look at the eyeballs. Okay, eyeballs have fluid with the vitreous content. If it is glowing, if it is fully white, then that's the T2 weighted images. That is what I used at the learning at the early part of the life. So MRI T2 weighted images, both T1 T2 weighted images, the air, fast moving blood, mineral rich tissues like the bones, okay, they appear totally dark. They don't show up at all, the bone. Okay, and if on the T1 weighted images, eye free or bone water tissue is there, like muscles and others. Okay, they look the grayish. I will show the gray color, second color. Okay, and here whereas on T2 weighted images, collagenous tissue, eye bound water, like T1 weighted images, and small bone islands, and all they look like grayish matter. Okay, little whitish gray proteinaceous tissue. Okay, little whitish gray, like muscles and all that. Again, the muscle has a lot of protein, myoprotein, so the little whitish gray is there. And whereas T2 weighted images, high boned water tissue, fat and fatty bone marrow, little whitish gray is there. Okay, and T1 weighted images and T2 weighted images, okay, completely whitish picture you see, mainly fatty bone marrow, blood products, slow flowing blood, radiation change, or paramagnetic contrast agents, they all appear the bright images as the paramagnetic contrast. That's why in T1 we give contrast agent to study specifically. Okay, and eye free water tissue like CSF and all that, they show brightly and T2 weighted images. Okay, so we need to remember this picture combination, okay, in order to understand this picture. Okay, there are many different sequences are taken. Okay, different sequences are taken, like T1, T2 weighted images. We also have a FLAIR images, DWI images, ADC images, T1 weighted, T2 weighted, T1 weighted with contrast images, gradient echo images, MR venography, MR venography with 3D reconstruction, MR angiography. Okay, we'll understand a little bit what it is there. What are the FLAIR images? Okay, mainly what happens is in the FLAIR image, it is like something like a T2 weighted images, but the CSF is suppressed. Instead of white, the CSF is in dark. Whereas any pathology adjacent to the CSF is there, that will be bright in the FLAIR images. Mainly because in T2 weighted images, the bright CSF, if any pathology is there in adjacent to the CSF, like in multiple sclerosis and those conditions, it will not show. So you have to suppress the CSF. Okay, that's why. So this flare images, if any edema, gliosis, lesions near CSF, they shown as bright this thing. It is mainly important for multiple sclerosis, new infarcts, and tumors. Okay, and this DWI images, it's very, we also use it for cholesteatoma, where restricted diffusion, mainly water molecule motion. There is a movement of the water molecules or not. If there is restricted movement, restricted diffusion is there, it's brighten up. Cholesteatoma, for example, there is no movement of the water molecules there, isn't it? It's cholesteatoma's tissue, keratin epithelium. There is no fluid, no water movement. So that's why the cholesteatoma and DWA images, it brightens up, isn't it? Okay. It also bright images it shows in stroke, abscesses, and tumor. Okay, the abscessor walled off. There is a peripheral ring formation walled off, so there is no movement of the water molecules. So in the tumor, in the stroke also. Okay, that's why they show brighten up. And the ADC, okay, again another diffusion coefficient, this thing. So again there is restricted movement. Okay, and anything restricted, because of that the tissues with restricted movement, they look dark, but if there is vasogenic, they look like bright. Okay, it's a controlled diffusion, actually quantified diffusion. It like once you do a DWI, if you want to confirm, you can take an ADC images, that is diffusion coefficient images, to confirm that restriction. Okay, gradient echo, this is main where the blood provides the dark signal words. Okay, so if there is a microbleed or blood or calcium, so this GRE, gradient coefficient, gradient echo images, gradient restricted echo images are done. Okay, so here for application for us, as far as the PNS and this thing concerned, it's not much, mainly for the neurosurgeons, neurologists. These are very, very, very important. For us, where it is important is mainly when analyzing tumors, or mainly the cholesteatoma. For as PNS concerned, the T1, T2 weighted images with or without contrast, they holds good for us. Okay, and also the signal characteristic, you should see, like, whenever there is sinusitis or mucoceles, it may contain a lot of fluid or proteins. Okay, so how the protein and fluids are seen on the T1, T2 weighted images. If protein is less than 10%, and T1 it looks whitish, and T2 look darkish. Okay, if more than 28% of the protein is there, the T1 it looks darkish. The protein increase, it looks darkish, whereas T2 it start brightening up. Okay, that's what we need to remember. Okay, the protein and this thing. Okay, no, this is more protein means in both this thing it brightens up. Okay, it brightens up, whereas in less protein, T1 is brightened and T2 it is not brightened. Okay, so these are the some signal characteristic we need to understand in this thing, in MRI. So this some little basic, only the key to understanding the MRI is the repeated viewing. We need to see that MRI repeatedly, then only we understand. Okay, yeah, that's about little understanding of the MRI. With this, we'll move on to the next presentation. That is pathology. Okay, so that is common pathologies. Okay, common PNS pathologies. Okay, we'll have just a 5-minute break. There is Zoom. Yes, let us continue. Continue with radiology in VNS pathology. Okay. Yeah, very important. Next, I already told you about this. The goals of imaging. The first goal is to identify the image, identify the lesion. Next, the site of origin. Okay, and what's the anatomical relationship to the surrounding structures, and differentiate the pathology depending on the pattern of the radiological appearance. Okay, and recognize infiltration and assess vascularity and distinguish the tumor from other lesions and help plan also surgical approach. These are our goals of imaging. So with this we should keep in mind whenever we study any imaging film, either CT or MRI. Role of the scan, we take both the bone windows as well as the soft tissue windows. The bone windows helps in determining anatomical landmarks and anatomical variants which we learned earlier and identify any erosive process of the bone. Whereas soft tissue windows, they detect extra sinus extension of the disease beyond the sinuses, okay? And also incidental brain, orbit, or neck lesions also we can identify on scans, very important. Whenever there is a unilateral opacification of the sinus, okay, what are the differential diagnoses we need to remember as shown in the picture here? If it is congenital, so it may be aplasia of the sinus or underdeveloped the sinus, okay, if there is a unilateral opacification. And it may be inflammatory also, which is common condition, okay, sinusitis, either it could be acute or chronic rhinosinusitis, okay. Or there may be a polyp or retention cyst, or there may be a mucocele also in unilateral opacification of the sinus like this, okay? Unilateral opacification of sinus. The other conditions are trauma, intrasinus hemorrhage, maxillosinus fractures, ethmoid fractures, afferental fractures, when they're filled with trauma, they give opacification of the sinus. And it can be neoplastic also, okay? It can have benign tumors like osteoma, antraconal polyp, inverted papilloma, even juvenile angiofibroma, or it can be odontogenic also, or it could be malignant also, squamous cell carcinoma, adenocystic carcinoma, adenoid carcinoma, lymphoma. It could be anything, okay? So all this can give rise to unilateral, all this can give rise to unilateral opacification of the sinus. So what we need to note, points to note, whenever we assess patient and the scans, take a clinical history, brief clinical history, and identify the pattern of the lesion and location of the lesion, and presence of mucosal thickening, opacification is the mass within the sinuses, okay, or any bony changes are there, and what the cause and complications we have to study. These are the points we need whenever we assess the films. So one of the case study here, let us this thing, okay, in between one question is that if some portion since morning is left, is it possible to relearn it? Of course, you will have a lot of opportunity to learn it, because but other than this, I'm going to post a lot of other articles and presentations into the app, okay. Case study, okay, this is an adult male patient, came with complaints of nasal congestion, thick postural discharge, headache and fever since only 1 week, and symptoms predominate in the morning and improve as patient is upright, okay. So this is the picture, okay. What we see is, oh, what happened? Oh, okay. So I wanted to show this, it went to the next slide, okay. So this is unilateral opacification of the sinuses there, okay, and there's a blocked sinus ostium, okay. You can see this on the opposite side also, we see there is some mucosal hypertrophy also, and also in the frontal recess area, some mucosal hypertrophy and some hypertrophy in the ethmoidal bulla also. So what is this? This is nothing but acute rhinosinusitis, because short history is there. So sinusitis is usually due to obstruction of the sinus ostium. It can be allergic, viral, bacterial, or fungal. It can happen to anything. So on CT, what we need to notice in acute sinusitis is there may be air fluid level, okay, or partial or complete opacification there, okay, and also there will be a mucous membrane thickening of at least 4 mm, usually uniform or nodular wave-like thickening will be there. If we examine these patients endoscopically into the sinuses, what we see nodular wave-like thickening will be there. and there will be a diffuse involvement as opposed to tumors where there is focal thickening. So this is one striking feature in sinusitis is whenever whichever sinus is involved, entire sinus wall will have a diffuse thickening. This is characteristic. Whereas in tumor, only focal thickening will be there. So what happens if we administer contrast agent, the CCT, there will be enhancement of the inflamed area. Okay, that acute rhinosinusitis, that mucous membrane, it enhances the contrast. Okay, so what are the points we need to know? This thing. Okay, and earlier we used to get a CT scan done in prone position, but we don't do it anymore. This mainly to prevent secretion from blocking orbital unit. But now what we use is we use 1 mm axial scans with the coronal reformations. The computer algorithm reconstructions. We do it. Okay. So now nobody does in prone position. This was earlier. It is there. It's mentioned in the books. It's not important anymore. And what we need to do is the presence of fluid. Okay, that's the most specific indicator of acute rhinosinusitis. In the absence of nasal lavage. Okay, patient has not done any nasal lavage recently. You have to take the test. If there's a fluid level is there, okay, that is acute rhinosinusitis. Okay. The next case study 2, a 30-year-old male patient with complaints of facial pain, nasal obstruction, nasal discharge, and anosmia since 4 months. Okay, here is what is. It's a bilateral disease there. Here we see complete opacification of the sinus, and here triangular opacification kind of. That means mainly the mucosa along the walls of the maxillary sinus is inflamed. But you also observe the bone surrounding the sinus here. Okay, the bone wall is kind of it is kind of thickened, and there is a lot of reaction in the bone. Okay, lot of the reaction in the sun. So where do we see this? We see in the chronic rhinosinusitis. So whenever there is sinus disease of more than 3 months, we brand as chronic sinusitis. It's usually unusual in children. Children come with recurrent URIs, okay, ERS symptoms. Okay, and if children are there, then you suspect local, foreign bodies or polyps. Okay, and 25% of the sinus, chronic sinusitis usually associated with the dental diseases also, sometimes orodental, fistula, orodental fistula, things like that. And chronic sinusitis, predominantly anaerobic infection may be there. So what we need to note in chronic rhinosinusitis is mucosal thickening and opacification. This is mucosal thickening and complete opacification there. So these bony walls surrounding, they'll appear to be thickened compared to the acute rhinosinusitis, and all kind of sclerotic reaction will be there, reactic new bone formation. This is hallmark of chronic rhinosinusitis. Okay. Now next time onwards, you observe these points when you see, look at the films. Okay. And the point to ponder, chronic sinus CT is study of choice in CRS patients for evaluating changes in bone, identifying anatomical variants that may predispose to recurrent disease. Okay, so that's the CT is the investigation of choice in the CRS patients, which we all of us know that. Mucosal thickening or opacification in non-expanded sinus with associated bone thickening and sclerosis most consistent with CRS. Okay, so this point, non-expanded sinus, this is very important because there is bone changes are there, thickening or sclerosis is there, and mucosal thickening is there. Okay, opacification of the sinus is there, but sinus is not expanded. So this is a very critical point we need to remember. Sinus retains this thing. We all know that what are the aims of FES? To improve mucociliary clearance of the sinuses by removing the diseased mucosa and bone that obstructs the sinus outflow tracts. Okay, so during CT, what are we looking at it? Look for anatomical variants that can predispose the patient to recurrent disease and affect operative techniques also, and critical variants which make surgery hazardous also. We should be very careful. Okay, like type 3 Kiros, type 3 skull base, that can make surgery hazardous also, but not in everybody's sense, not in experienced surgeon sense also. That's why the preoperative CT scan is provides data for intraoperative stereotactic guidance. So that is the crucial matter. Okay, and this is another patient, a 30-year-old man, immunocompetent patient, non-atopic means no HF otherwise healthy patient means he doesn't have any other condition, hypertension, diabetes, is not complaining, presenting with only mild sensation of pressure overlaying left maxillary sinus since 5 to 6 years. Okay. Yeah, here you can see again unilateral opacification of the sinus. Okay. And other than that, slight reaction of the sinus walls is there, but compared to this sinus, little expansion of the sinus is there. And also what you see, some double density or mineral content within the site, you can see. And many of you may have arrived at the diagnosis if this such double density sinus seen. Okay. And here an axial, this is coronal, not axial, shows opacification with high density material centrally containing multiple calcifications like seen are there, and thickened maxillary sinus walls and expanded walls also. So that means this is mainly fungal sinusitis or mycetoma. Okay, so we have to remember this. Okay, another case study: a 50-year-old uncontrolled diabetic patient. That means is immunocompromised. You may have arrived at a diagnosis also. Acute onset of fever, epistaxis, sinus pain, headache, cough, and nasal mucosal ulcerations and crusting is there. Okay. An examination here, left periorbital swelling patient had, and also a proptosis was noticed. So what did we see on a CT scan here? Same. Okay. Unilateral opacification sinus, but we saw some bone destruction along the floor and medial wall of the orbit, and also we saw some double density, and also we saw this soft tissue density extending into the orbital content. Okay. So coronal CECT, soft tissue in the right maxillary sinus, okay, infiltration of the orbit with bone destruction that was noticed on CECT also. So that is invasive fungal sinusitis, okay, acute invasive fungal sinusitis. So there's another condition here. A 22-year-old immunocompromised, immunocompetent patient is not immunocompromised, and complains of on-off nasal obstruction, rhinorrhea since 1 to 2 years, and also he has history of nasal allergy. At an examination, we found nasal polyps. Okay, and he has got increased serum eosinophilia and IgE levels. Okay, and here you see a kind of again double density, but kind of layered structure is there, and also expansion of the sinus is there a little bit. And you can see here expansion of the ethmoid sinuses here, and a little bit of rarefaction, and not erosion. You can say rarefaction of the bone walls. That is also seen. Okay, and coronal section mixed density material this is. Okay, and opacified and expanded ethmoid and sphenoid as well as maxillary sinus. Okay, so this is allergic fungal rhinosinusitis. That is what we call EFRS. If you see, examine the nasal cavity, you will see a lot of allergic mucin, yellowish color allergic mucin. You will see. So whenever we study rhinosinusitis, we should also study for the complication of the sinusitis. So what are the complications that can happen in acute rhinosinusitis? There may be orbital complications like subperiosteal abscess, orbital cellulitis, and intraorbital abscess. Intracranially, the meningitis or intracranial abscess can happen. Okay, and vascular complications like venous thrombosis, arterial thrombosis, aneurysms can occur. We saw this lot of arterial thrombosis during mucormycosis. Okay, osteomyelitis can occur. Okay, osteomyelitis can happen, and in chronic mucociliar polyps can happen. Okay, so that we need to keep in mind. Okay, so here the previous this is on the patient who had pansinusitis involving ethmoids and post-ethmoid sinusitis. Okay, what he had was again this patient presented with a proptosis and severe headache, facial pain, and personal discharge. Okay, he had acute sinusitis, and also you can see orbital kind of abscess. Okay, subperiosteal abscess, which is pushing the eyeball out. Okay, this is subperiosteal abscess. Another case of sinusitis. Another case of sinusitis. Okay, this is again patient had orbital abscess. This is extending to the ethmoid sinusitis. It is extending on one side ipsilaterally to the orbital cavity also. Okay, this we need to note because these are some cases. If you treat early, you can give magical results to these patients. Okay, noting this and interfering this at an early stage. This thing. So another patient had orbital abscess Incidentally, he also had cavernous sinus thrombosis, which was diagnosed on a CECT. The absence of flow in the cavernous sinus is indicative of cavernous sinus thrombosis. Okay, absence of blood flow when we do the uh, contrast CT scan, that will indicate that there is a cavernous sinus thrombosis. That we need to remember. So whenever complications are there, so we have to consider, we have to ask some questions. Is patient asymptomatic and immunocompetent? Okay, is a single sinus involved? Okay, and if you're done an MRI, do not mistake low T2 signal for air. Okay, because sometimes fungus also can mimic air. That we should be careful. Okay, be careful, and we should be sure of looking for any signs of invasive disease in all these patients. And some more points we need to remember is we have to consider invasive fungal sinusitis in immunocompressed patient with myxosinus disease and dirty periantral fat if no bone erosion is also present. Okay, so what happens is, what is periantral fat is, you will see surrounding the sinus, you will see a lot of edema. Okay, that also we should note, and we should evaluate the orbit and intercavities for whenever there is invasive fungal sinusitis. These patients require MRI, and we have to look at the cavernous sinus and also orbit and intercranial cavities for any involvement. Allergic fungal sinusitis, we should consider allergic fungal sinusitis and increased density in multiple sinuses with expansion. Okay, often concurrent polyposis will be there. And allergic fungal sinusitis, you will not make a mistake. Okay, if you examine the nose, there will be allergic mucin, yellowish color allergic mucin will be seen, multiple polyps, pale yellowish polyps will be there. Okay, and double density expanded sinuses. Okay, that you will see, but you will not see the bone erosion. Like, you will see the expansion of the sinuses, but you will not see the bone erosion. Okay, okay, and the soft tissue algorithm and non-enzyme CT scan for identifying increased attenuation areas. That's what. So we go back to that picture, soft tissue attenuation. Remember this. This is the double density with soft tissue attenuation. This is a soft tissue window where it shows the double density and expansion of the sinus on allergic fungal sinusitis. Okay, so that we need to remember when we assess the disease. Okay, so next case, 25-year-old male allergic patient with progressive nasal stuffiness and obstructions and sensation of secretions that cannot be expelled since 5 to 6 months. So you'll have this sensation. and examination, you will see multiple polyps in the nasal cavity, and the scans also, you don't see that expansion of the scans. Okay, sorry, sinuses. Okay, and also you may not see double density also, but multiple soft tissue, nodular soft tissue densities are seen. Okay, and multiple polypoid soft tissue masses within the nasal cavity and paranasal sinuses, and usually bilateral. Okay, bilateral mainly in the antinasal cavity seen. This is sinonasal polyposis. That's simple. Okay, and consider if density of expansile polyps is increased, the signal is heterogeneous in MRI. Allergy fungal sinusitis in setting of polyposis is likely. So since the chance of AFRS, allergic fungal sinusitis, are high, so you should always look for this double density sign in these patients. Okay, yeah. And polyps occur in sinus and nasal cavity. Mucous retention cysts are typically located in sinus only. So while the polyposis, they are there in the nasal cavity as well as outside. Okay, in the nasal cavity as well as within the sinuses. You need to remember the benign polyps, the benign cysts, they present only in the sinus. Okay, this hello, please don't write on the screen, please. Okay, doctor, please, can you wipe these lines? It is little disturbing for me. Okay, and this is the next case study, a 17-year-old male patient. And Dr. Gurmeet, please, can you remove these lines? A 17-year-old male patient with complaints of left-sided nasal obstruction with with mouth breathing and snoring since 1 or 2 years. Okay, yeah. So patient has a nasal obstruction, and this thing on examination, what you see a small sinus compared to the opposite side, and which is totally opacified. Okay, totally opacified, and so this is a 1 minute. This is a different case. This is a wrong CT scan has come. Okay, so this is okay, and this is homogeneous mucoid density mass extending from maxillary antrum through widened ostium into the nasal cavity and choana. Okay, and this is nothing but antraconal polyp. Okay, unilateral polyp. Okay, it's coming out from the maxillary, you will notice. Okay, and going posteriorly. For any benign disease, you only need a coronal sections and enhanced CT scan. Okay, and if bone CT appearance is atypical, then you have to consider MR with contrast to rule out central enhancement. Okay, any pathology and this thing, and mucoid density and signal antraconal mass with thin rim of peripheral enhancement is characteristic of antraconal polyp. Okay, any nodular enhancement also rules out antraconal polyp. Okay, and do not mistake nasopharyngeal component for nasopharyngeal neoplasm, and look for ipsilateral opacification of the maxillary antrum even if stock is difficult to see. So the moment the patient has some nasopharyngeal mass, so don't confuse it for see some malignancy. Okay, look for a CT scan. Do a CT scan, and if you see that there is a unilateral enhancement, isodense mass coming with the maxillary widening of the maxillary antrum, and the same mass is going behind into the nose and nasopharynx into the choana, and it may be hanging. It is seen on the examination hanging into the nasopharynx and oropharynx. So that means that's a antraconal polyp. Okay, don't confuse it. Okay, and some retention cysts are small cysts within the sinuses. Okay, these are usually homogeneous soft tissue mass with smooth borders. Okay, not filling the complete sinus. It's separation from the underlying bone, and they will clearly separated from the underlying bone, have no attachment at all. Okay, and these are usually the this thing, benign cysts. We see a lot of benign cysts. Let's see. Okay, this is another case. 45-year-old of male patient with complaints of painless enophthalmos. He has got an enophthalmos, but he has no pain, and there may not be facial asymmetry, and there may be diplopia with no history of any head trauma. Okay, no trauma, nothing. These conditions are slowly happening, enophthalmos and facial asymmetry and diplopia. Okay, and examination. Actually, this picture was supposed to come here, so unfortunately somehow it went it went there. Okay, no problem. Yeah, this picture was supposed to be here. This patient also had an ophthalmos unilateral. Okay, and an examination, he had small maxillary sinus. Okay, an examination maxillary sinus. Okay, this is okay. Yeah, this is the one. And opacified right maxillary sinus, inferior location of the roof of the sinus, and occlusion of the maxillary sinus, ethmoid infundibula, maxillary sinus infundibula. So this is nothing but silent sinus syndrome. Okay, silent sinus syndrome is a painless involution of the maxillary sinus after occlusion of infundibulum with associated enophthalmos. Okay, most cases are idiopathic. You don't know what's the cause. Usually it happens in in active life, that is 25 to 75 years. The best diagnostic clue is retraction of the maxillary sinus walls with diminished sinus volume. That is the best this thing. Here, 32-year-old male patient complains of it's not frontal bossing, the maxillary, the cheek bossing was there with okay. In the mainly, this was actually different history has come. In this patient, there was no frontal bossing. The swelling over the cheek, he came with a cheek swelling actually, and had a hemifacial pain. Okay, on examination, what he had was this isodense mass. Okay, and peripherally you can see thin rim of bone around it. Okay, here if you see carefully. Okay, and this is the isodense mass, and the coronal and axial CT usually opacified expanded. This ethmoidal sinus was there, and then the mainly medial wall of the maxillary sinus. Okay, and this is the This was a Ethmard mucocele. Okay, so mucoceles are nothing but expansion lesions of the paranasal sinuses, and mainly due to obstruction of the sinus ostium. Okay, so the airless sinus. So that's where the mucus starts collecting and start expanding. Okay, expansion and remodeling of the bony margins. This is critical for diagnosis. Okay, I showed you. So there is expansion and remodeling of the bony margins will be there. So that we need to remember, and displacement of the adjacent structures. So in this case, it may be the orbit, the contents of the orbital contents may get displaced, and usually these mucoceles are seen majority in the frontal is about 65% of the patients, and ethmoid in 25% of the patients. I've seen personally mucoceles in very different locations. I've published a paper also on that, say, the mucoceles on different unusual locations, and they can present with proptosis or nasal obstruction, varied symptoms, mainly because of the size. Okay, and CT scan, expanded airless sinus with homogeneous material of flow attenuation with 10 to 18 ounce field units. Okay, so this is another one. So what you have to notice is the peripheral, the expansion of the sinus, and thin bony rim around the lesion. Okay, and uniform consistency tissue within the sinus. Okay, density. So look for thin peripheral rim of expanded bone and no central enhancement on post contrast CT or MR. Okay, you won't see any enhancement with the contrast. Okay, and this mucocele, it appears bright on T2 images, but it doesn't take any contrast. Okay, and extensive peripheral enhancement may suggest mucopyocele sometimes. Okay, yeah, sometimes can get infected, become pyocele. So in that case, the extensive peripheral enhancement, the ring enhancement will be there. Okay, if there is a central enhancement, then you should consider it as a neoplasm. Okay, yeah. So this is another case, 45-year-old male patient with nasal obstruction, epistaxis, anosmia, purulent rhinorrhea, hoarseness of voice, stridor, hematuria since 2 to 3 years, and the symptoms not relieved even after taking medication for rhinosinusitis. Again, you see here mucosal hypertrophy in this sinuses, and you see a lot of reactions in the surrounding bone. Okay, you see a lot of hyperestosis and sclerosis in the bone. Okay, yeah. So what is the extensive soft tissue with bone destruction, and also in this septal perforation is not there. So this case, but septal perforation can occur. Okay, and nodular tissue in the megasinus with medial wall erosion, you may notice that also, and sometimes the retroantral fat and pterygopolitan fossa edema. You can notice that also in some cases. So that is vaginatus glandulomatosis. So we should keep this as differential diagnosis whenever such pictures are seen. Okay, when you see such pictures, chronic picture. If it acute, that patient has immunocompromised status, acute status, it's an acute invasive fungal sinusitis, maybe mucor. If it is a chronic, slowly progressing tumor and gives this kind of picture, then you should think of granulomatosis. Okay, and vaginous granulomatosis is a non-neoplastic, aseptic, necrotizing vasculitis that preferentially involves upper and lower respiratory tract and kidneys. We have read it as UGs and PGs. The etiology is not completely understood even as of now. Best hypothesis is autoimmune disease is considered, and 90% of the patients initially experience head and neck symptoms. Okay, and clinical issues, there may be nasal obstruction, epistaxis, chronic rhinosinusitis. These are the principal presenting complaints, and usually they present in the adult life between 40 and 60 years, more common in male patients. And the best diagnostic clue, soft tissue mass in nose with septal and non-septal bone destruction may be there. Okay, yeah. Consult with clinical for history of cocaine abuse or other organ system involvement. Okay, cocaine is not there in India, don't have to worry about it. Can look for very similar to nasal lymphoma. Lymphoma is one differential diagnosis we have to keep whenever such patient come to us. Okay, and whether should be considered when destructive process centered in nasal cavity, particularly when septal perforation is present. Okay, yeah. Next, we also have to keep neoplasms. What are the neoplasms that can occur? Okay, we have benign and malignant neoplasms. The epithelium papilloma, aplioma, adenoma can occur. juvenile angiofibroma, hemangioma, neurogenic and meningioma can occur, osteoma, fibrous dysplasia, okay. Aneurysmal bone cysts can occur in the osseous lesions, okay, that's ABC. And epithelial lesions, squamous cell carcinoma, salivary tumors, neuroendocrine carcinoma, olfactory neuroblastoma, malignant melanoma can occur, okay. And the mesenchymal lesions, rhabdomyosarcoma, osteosarcoma sarcoma can occur, and lymphoma, plasmacytoma, metastatic lesions can occur. The main clinical presentation may remain clinically silent in the sinuses, mainly paranasal sinus, until they reach advanced stage. This is one thing we have to remember. And when in advanced stage, there may be a pain and perineural invasion may be there. And sometimes patient may also present with diplopia, proptosis, anosmia, epistaxis, and facial mass. Okay, and there may be nodal metastasis. And one of the if there is a nodal metastasis, that's one of the gravest prognostic sign, in paranasal sinus carcinomas that we have to remember. So, what are the salient features of malignant lesions? Well, lesions of the sinuses, making difficult to distinguish from inflammation, that we have to remember. Okay, so therefore the MRI has superior results. Inflammation due to high water content have high signal on T2 weighted images. Okay, so on MRI they look brighter in all the malignant lesions. The sinusal tumors intermediate signal on T2 weighted images, and the sclerotic bone more commonly seen with inflammatory or granulomatous disease. Okay, but whereas in bone, in the malignant lesions, we see more of erosive kind of picture as far as bone concerned. Okay, if you see sclerotic bone, it's mainly inflammatory or granulomatous disease. Okay, and discrete solitary or multiple calcifications within a mass signify chronic inflammation. Okay, calcification is sign of chronic inflammation rather than the malignancy, that we need to remember. Okay, so the pattern of bone involvement we need to remember this lesions is the bone destruction is seen in squamous cell carcinoma, undifferentiated carcinoma, and metastasis. Okay, and destruction remodeling of the bone. Okay, there may be sclerosis. This is mainly seen in benign condition like aggressive chronic infection or inflammatory pseudotumors. Okay, bone remodeling is also seen mucocele, polyp, angiofibroma, inverted papilloma, adenocarcinoma, lymphoma, or melanoma, or sarcomas, or schwannomas. There it's the scene. Okay. Okay, this is about some benign tumors of the larynx. Okay. Yeah. Any questions on this? Yeah. My request, please avoid writing on the screen. Yes, if central enhancement present, then it could be fungal sinusitis. So can also occur, but fungal sinusitis you will see the extensive bone erosions. Okay, yeah, you will not see the expansion of the sinus in fungal sinusitis. Yeah, that is one differentiating feature, Dr. Pallavi. And also, okay, central enhancement means you should suspect to be neoplastic. Yeah, you're right. Yeah. Anosmia without history of allergy or nasal obstruction. Yeah, the AFRS, there will be silent bone. I mean, sorry, the bone, the sinus expansion will be there. But see, the sinus expansion, along with that sinus expansion, there is a double density sign in allergy fungal rhinosinusitis compared to the mucocele. Mucocele is uniform density will be there. Okay, yeah, that is the AFRS. And coming anosmia investigation, usually unless obvious any lesions are there, you can do a CT scan, simple non-enhancing CT scan, screening CT scan. Otherwise, most of these patients will not have any findings on MRI. Most of the times it's viral etiology.
Thank you very much. Going on.
We don't this thing,
Proceed.
yeah.
Proceed.
Do a diagnostic nasal endoscopy.